Okay. Okay.
Right?
Yeah.
Yeah.
Okay, everybody. This work represents a team effort over a number of years. So I certainly don't take credit for all of this work myself. I'm very much appreciative of the team effort that's gone into this. I've not named any of my students or my colleagues because inevitably I will leave some out and cause offence, but there is a tremendous number of students, probably certainly 30 students, maybe 40 students over the last few years who contributed to this work, and similarly in a large number of colleagues as well, both at University of Toronto, University Health Network, Waterloo, the Ontario Neurodegenerative Research Initiative as well. All of those agencies or institutions are have contributed tremendously, and the funding agencies there as well are actually listed, and I hope I've got them all so that I don't cause offence. Can I have the next slide, please? Thank you. As Carlos said, my name is Chris Hudson. I'm a professor at UW and also cross-appointed at U of T. I was a senior scientist at Krembil Research Institute, but I've stepped down to affiliated scientist this last month at the Toronto Western Hospital. I'm Ocular Platform co-lead investigator on the Ontario Neurodegenerative Disease Research Initiative, or ONDRI, and I came to Canada in 2000. So I've been here now nearly 20 years. Next, please. The aim of the webinar is to describe non-invasive biomarkers for the objective quantitative assessment of retinal vascular integrity in diabetic retinopathy and retinal morphology in neurodegenerative disease. I've also done a lot of work on retinal blood flow and retinal oximetry, which can also be used as biomarkers, but I'm not going to describe that work today, just for the sake of time. So what is a biomarker? A biomarker is any measurement of a substance or magnitude of a physiological measurement, sometimes in response to a provocation, that indicates disease status in an organism. So it's an indicator of normality or abnormality, and it also hopefully indicates progression or regression or stabilization. And such biomarkers have been used for years, of course. Things like intraocular pressure, blood pressure, etc., are all in their own way biomarkers. In terms of some of the aspects that I'm interested in, the testing of drugs in clinical trials, for example, it's important that the biomarker chosen to demonstrate drug efficacy is objective, quantitative, sensitive, specific, and reproducible. Next slide, please. Thank you. The advancement of technology has resulted in huge steps forward in terms of development of imaging of the retina in the living human eye. And one of those technologies is called Spectral Domain Optical Coherence Tomography, SDOCT. It has literally revolutionized the clinical management of many retinal and ocular diseases such as diabetic macular edema, age-related macular degeneration, and glaucoma. With this technique, we can actually detect previously irresolvable retinal structures in the human eye. Commercial SDOCTs are now able to detect change in thickness at the level of 1 micron, permitting visualization of the retinal sublayers. Technique provides an objective evaluation of retinal morphology with relatively high sensitivity, and it has a high speed of acquisition, relatively low cost of running, and it has become a common investigative technique in eye care clinics worldwide. The technology continues to be refined, and that in a way creates a challenge because as the technology is refined, the approach in terms of analysis or looking at the images, if you like, has to change as well. Next slide, please. These are just some of the commercial SDOCTs. There's at least 5, probably 8 different makes now available. Next slide, please. Basically, SDOCT is a combination, if you like, of ultrasound and MRI. It's similar to ultrasound, but it uses light instead of sound waves. And basically, it measures reflection as a function of depth within the retina to actually then produce a 3-dimensional image of the retina itself. And with the technique, the sensitivity of the technique is such that we can actually pick out the sublayers of the retina. So there are about, depending on how many lines you wish to delineate, there are 8 and maybe 10 layers to the retina itself, all aligned like a piece of plywood. So the layer on top of layer on top of layers. Next slide, please. The slide on your left is a histology slide, whereas the one on the right is an early SDOCT slide, and you can actually relate the two directly. So the slide on the right is non-invasive. Keep in mind that the retina is transparent, so we can see these layers by shining an appropriate light through the section of the retina and picking up the reflections at each depth. Next slide, please. In terms of biomarker development, the advent of technology like SDOCT provides an opportunity to exploit that technology. There are various ways of doing that. One is to use the new technology within an unusual application. One of the things that we've been looking at in my work, my lab, has been vascular integrity of the retinal vessels. So if we provoke increased blood flow to the retina by lying the subject on the back, that in effect pumps more fluid into the retinal tissues. The perfusion of the eye is governed by blood pressure, which is a positive perfusion, and intraocular pressure, which resists perfusion. In this respect, the eye is unique, having very high external tissue pressure, typically around 15 millimeters of mercury. If we're measuring ocular perfusion pressure using a cuff on the arm, ocular perfusion pressure is 2/3 mean arterial blood pressure minus IOP. The constant of 2/3 is there because of the fact that the eye is higher than the heart, and blood has to be pushed against gravity up the carotid artery and ophthalmic artery in order to get to the eye. However, if a person is lying down, that factor of 2/3 is no longer relevant, and in the lying position or supine position, OPP or ocular perfusion pressure is equal to mean arterial blood pressure minus IOP. Next slide, please. If we take a mean arterial blood pressure of say 70 to 100 millimeters of mercury and an average IOP, typical mean arterial blood pressure of 90, let's say, the OPP, ocular perfusion pressure, when standing is roughly 45 millimeters mercury, and when supine is 75 millimeters mercury. So what we're seeing there is that by lying somebody down, we create a provocation to push more fluid into the retinal tissues. Next slide, please. A key aspect of diabetic retinopathy is blood-retina barrier integrity. And typically what we see in patients with diabetes are microvascular changes that erode the blood-retinal barrier, resulting in leakage into the retina. These microvascular changes also reduce the retinal vascular reactivity of the arterioles, and that reactivity in the normal situation, in lying down, the arterioles would constrict and reduce the blood flow to the eye. But if you have compromised reactivity, then that cannot happen. And the stimulus for overperfusion of the retinal tissues becomes more exaggerated again. Clinically, blood-retinal barrier leakage is manifested as diabetic macular edema, which is the largest cause of vision loss in people with diabetes. Leakage is assessed using intravenous fluorescein angiography, which is not quantitative. It can result in allergic reactions. It frequently results in allergic reactions. Sometimes, unusually, those can be severe. It's relatively expensive to administer, and it's often overlooked in clinical situations, just quite simply because it's time consuming to do and difficult to do. We know that there is a subclinical diabetic macular edema present in a large proportion of people with diabetes. And previously there's been a diurnal variation in macular edema noted by others using SDOCT. We looked at this issue in a preliminary study using 10 patients with diabetic retinopathy, some with edema, some without, and 13 age-matched controls. Next slide, please. Basically what we did was we measured the retinal thickness with them stood up or sat up. We measured retinal thickness when they were lay down over a period of 2 hours, and then we measured them again immediately after returning to a sat up position. Next slide, please. We measured retinal thickness in these quadrants. So the slide on your right, or the diagram on the right, shows the global area or sector, and we then dissected that in effect into a central area of 1 millimeter diameter and superior nasal, temporal, and inferior sectors. Next slide, please. And this just shows how the effect some of the SDOCT scans during that study. In order to measure the person lying down, we had to measure them on the side. So we kept them horizontal, supine position, but moved them onto the side. We removed the headrest from the instrument so that we could get the instrument head, the scanning head, close enough to the eye. And subsequently, we had to transpose those images with the patient on the side so that it correlated with the position, the retinal positions of the patient sat up. So we transposed the image through 90 degrees so that we compared equal or equivalent sectors between lying down and stood up and sat up. Next slide, please. This just shows mean retinal thickness for the various time points, which you can see as the legends, the plot legends, the open circles and the closed circles. For each of the sectors, so the first one on the left is global, the next one along is central, and temporal, superior, etc. The open circles are people with diabetes or diabetic retinopathy, and the closed circles are healthy controls. And basically what the results are showing, if you look in the temporal sector in particular, you can actually see that these patients, when they lie down, show a large increase in retinal thickness. That's something like a 20 micron average increase in retinal thickness between being initially sat up, upright, And then after a few minutes of lying down, there's a huge increase in retinal thickness. There is a similar increase in retinal thickness in the healthy controls, but it's a much lower magnitude of response. We actually think that this response, or this response to the provocation of lying down, could be a useful biomarker to look at retinal health and diabetic retinopathy progression, etc., and response to treatments as well. Next slide, please. This is just showing you for that temporal area the magnitude of change. So the box and plots legends are for the controls are the hatched ones, which stay very close to the zero change line, and the open box and plots are the diabetic results. And basically you can see there is a huge difference in response to this provocation of just lying down for even a short period of time. This response happens very quickly. It does continue over the 2 hours. As you can see, the box plots, the open box plots increase for the first 3 time intervals and then reduce almost back down to normal. And that change back to normal again occurs within minutes, not tens of minutes, within 3-4 minutes. Next slide, please. So in conclusion, results explain why people with diabetes may experience blurred vision on waking. That's a common complaint of many people with diabetes. And the effect is not a true diurnal variation as suggested by others. Rather, it appears to be a response to adopting supine body position. As I said earlier, the group mean retinal thickness increased by over 20 microns in the temporal grid sector. Implications of this work, there's many implications. Life adjustment, should people with diabetes sleep with the head up? Would that slow the progression of retinopathy? We still have to find that out, and that's work in the future. And the research is leading to the development of a clinical test for early detection and monitoring of treatment response in DME. It may well do. Not sure if any of you are aware of spaceflight associated neuro-ocular syndrome, but the astronauts on the International Space Station, if they're up there for long enough, are developing a form of neuropathy or atrophy of the visual fibers that course from the eye to the brain. And people don't know why this is happening. It probably relates to the fact that in a non-gravitational environment, the heart is over-perfusing the eye because it's used to pumping that column of blood against the force of gravity. That's what we're thinking. So this has relevance to SONS as well. This is work in progress. It was done a number of years ago, but it's something that I picked up. Subsequently, we've gone back and looked at it and felt it's worthwhile pursuing. And that was one of my students, Abdullah Al-Zugabi, who finished his MSc in 2015. We actually have grant proposal in preparation for this. Next slide, please. There are many sides to all of us, and I guess one of the sides that I have, which makes me a little different from some, is that I've lived with Parkinson's disease for 17 years now. I was diagnosed with young onset Parkinson's disease at 41 years of age. I'm still working full time. I have an aggressive attitude towards managing my PD. I exercise daily, close attention to my medical regime, careful diet, attention to body signs. I work as an advocate or activist for the Parkinson's disease community. I was recently awarded an Ontario Volunteer Service Award for this work. Next slide, please. PD, Parkinson's disease, is a poorly understood and appreciated disease. It impacts every system in the body: cardiovascular, digestive tract, genitourinary system, respiratory tract, brain function, senses in addition to vision. Taste is lost, touch and pressure, feelings in your feet can be lost. And it particularly impacts complex integrative systems like balance, mental well-being, facial expression, voice projection. Also, things like binocular vision, convergence, eye movements, that sort of thing. It's has impact on all of those functions. So it's not just a movement disorder as it used to be classified. PD is hard on partners and the whole family. The symptoms displayed by people with Parkinson's can often be experienced by close family members as well. Next slide, please. Dopamine plays an essential role in vision. It's actually a messenger within the retina, and it is released by the amacrine cells, which are in sort of deeper retinal layers. And people with Parkinson's have reduced retinal dopamine as well, we think, and that is thought to result in problems with contrast sensitivity. So a lot of people with Parkinson's will complain of poor vision when night driving and that sort of thing. Next slide, please. The clinical diagnosis of neurodegenerative disease. So here I'm widening the story now. So Parkinson's is one of a number of neurodegenerative diseases. The others would be Alzheimer's, stroke is another cause, frontotemporal dementia, Lou Gehrig's syndrome as well, Lou Gehrig's disease, are all neurodegenerative diseases. The current clinical tests for NDDs typically offer low specificity and low sensitivity. Their diagnosis is typically reliant upon subjective evaluation and clinical intuition of the neurologist involved. It can also very often rely upon a positive response to therapy or upon a definitive decline in function over a short period of time. Basically what I'm getting at here is there's no definitive test for any of the neurodegenerative diseases. There is a dire need for the development of non-invasive objective tools to improve the clinical management of people with NDD. For example, if we take Parkinson's, the last technological breakthrough for the treatment of PD was the introduction of levodopa or Sinemet 50 years ago. An absence of objective tests with high sensitivity and specificity to non-invasively categorize and detect change has been identified as a barrier to the development of new treatments. Potential new treatments exist, but assessing their efficacy is very difficult, while no clinical tool exists to evaluate NDD status. Next slide, please. So why is Andre interested at looking at the retina? The evidence is mounting that the retina basically is an extension of the brain. It also manifests morphological changes in neurodegenerative diseases as well as the brain. The retina is an appealing target for non-invasive optical imaging and the surrogate quantification of these diseases. Basically, I feel very strongly that the retina may ultimately have a role in diagnosis and monitoring of these diseases. This is not a new idea. Just go back a little. One slide, please. Thank you. This is not a new idea. Leonardo da Vinci was talking about this, and basically is documented the fact that he felt the eyes were a window to the soul. So in many ways, he knew the potential of the eyes even thousands of years ago. So next slide, please. Thank you. Neurological applications of SDOCT are basically, it could perform or could be developed into a surrogate marker to assess NDD. Death of cortical cells is suggested to trigger retinal ganglion cell death. Interestingly, there are some that believe that there's a potential for the trigger for NDDs to even work in the opposite direction. So in other words, to come from a peripheral nerve, and then impact the central nervous system or brain. There's been a number of relatively small cross-sectional studies which have found retinal thickening in Parkinson's, Alzheimer's, and other NDDs. Retinal nerve fiber layer thickness, in particular, appears to be thinned, may reflect retinal ganglion cell death, secondary to degeneration of cortical neurons. Thickness of the neural retina has also been suggested to correlate with a reduction in grey matter volume in patients with early onset Alzheimer's. The retinal layers, some retinal layers are also thought to thicken. And there's huge controversy in this area. And in many ways, the controversy actually creates an opportunity since it suggests different things are happening across the various neurodegenerative diseases. Next slide, please. This is the graph which illustrates the relationship between retinal nerve fiber layer thickness and severity of Alzheimer's disease. And a precursor of Alzheimer's disease is mild cognitive impairment, so MCI. Then we go on to mild and moderate and severe AD, and across those categories, you can see that retinal nerve fiber layer thickness seems to reduce. However, it's not that simple, and we'll talk about that a little in a second. Next slide, please. So the ONRI study, which I've already mentioned, is a huge study. There's more than 50 co-investigators on the study, and it's principally funded by the Ontario Brain Institute. It represents a collaboration of a huge number of institutions as well. Next slide, please. As I said earlier on, I could not do any of this without people, a team of people behind me, and here are some of my current team. Wendy Hatch, Dr. Wendy Hatch is an assistant professor at University of Toronto. Ayan Tayari is a postdoc whose home institution is University of Waterloo, but who is based primarily in Toronto at the moment. Ayan works for both Wendy and I in order to get the study, continue the study development and forward progress. Margot, Richard, and Brian, Anna, who's not shown, and Asim are all valuable students, very successful in their own rights, and tremendously thankful for their input into this work. Next slide, please. This is why I didn't put names at the beginning of the presentation, just quite simply because there's a huge number of people involved, and I'm sure with this list here that I've missed some of them off, but you can actually see it's an impressive group of people. I should say that the principal investigator of the first ONRI study grant was Michael Strong, who's now president of CIHR. So Michael Strong had a huge part in the setting up of this study, and we've since had refunding from the Ontario government, and I suspect again we will be going back to for more funding in the future as well. Next slide, please. So the causes of dementia in NDD are Alzheimer's, ALS, frontotemporal dementia, Parkinson's disease, and vascular cognitive impairment or stroke. They are the disease sections of the ONRI study. And then we have investigation platforms of genomics, neuroimaging, neuropsych, gait, ocular, and neuropathology. All of that data flows into the neuroinformatics team, and they clean the data up and then return it to us. And we then analyze it. We analyze it with the help of the neuroinformatics people as well. Next slide. In terms of the ONRI study, our lab collected data from 3 cities: London, in Ontario, of course, Ottawa, and Toronto. Other cities that were part of the ONRI study but did not recruit for SDOCT included Kingston, Hamilton, Thunder Bay. The whole process is very automated. Data is backed up to a central repository, and everything goes through that central repository called brain code. Standard protocol was used to acquire these images. Next slide, please. This just shows the study subjects, their mean age, male to female ratio, and as you can see, we've got overall, including age-matched healthy controls, we've got at least 230. I think we'll probably end up with final numbers of around 250, 260 across the various diseases. Next slide, please. Again, this is just this is the full ONDRY study, if you like, the over 600 participants. We didn't reach that 600 number because we weren't receiving patients from every data collection center, basically. Next slide, please. We have paid attention to confounding factors, and the one thing about these patients is that many of them are elderly, and so there is concomitant pathology which can impact the results. So things like epiretinal membranes or drusen, which are normal aging processes, can actually impact the results of what we're trying to measure. Next slide, please. I mentioned to you earlier that there was a lot of controversy in terms of what exactly happens in the retina with neurodegenerative diseases. Just a month or two ago, this paper appeared in Scientific Reports, Nature Research, and it showed that not only were layers, individual layers thickening or thinning, but within a layer, you could actually have thinning of the retina or thickening of the retina side by side. Next slide, please. So these are some of the first results from the ONDRY study. These have not been seen by many people. In fact, I think the only people that have seen these are the grant reviewers that the project is currently applying for funding to. So you have mean retinal thickness in microns over the large scan area of the retina for as a function of age for Alzheimer's, ALS, frontotemporal dementia, Parkinson's, and vascular cognitive impairment, running left to right, upper to lower. We go on to the next slide. I didn't expect these slides to show much difference, and I'm pleased that they didn't, because these are large area assessments of retinal thickness, or in this case, retinal volume. The retinal volume is interesting because it does tend to show that the volume of the retina reduces as a function of age. There's a slight slope, if we put best fit lines, that is higher on the left and lower on the right across those 5 diseases. But we need to look at controls before we can say too much about that and decide whether the slope of the line in controls is the same as in the various NDDs that we have here. Next slide, please. So in conclusion, these preliminary results using full field scan suggest a trend for reduction in overall volume with increasing age, but we cannot say too much about that until we have the healthy control data coming through, which we're collecting at the moment. Careful checking of retinal segmentation software is required, but thankfully we've demonstrated that this need not be too onerous. The data is not shown here. And point-wise analysis is crucial to detect small magnitudes of change in these images. If we use just diffuse parameters, we will miss some of the changes that the technique is actually picking up. And this relates to what I said earlier about SDOCT developing and the need for the analysis of the images to similarly develop. This is work in progress. The grant proposal is in submission, and hopefully we'll get a good outcome to that soon. And next slide, please. Thank you.
All right. Thank you, Dr. Hudson, for a fantastic presentation and sharing the research that you're leading up and bringing the personal side of why you're so passionate about the work that you are doing. So we are opening it up to questions. I can start things off. The first question that I had was what makes Waterloo such a hotbed for health research and development? There's a lot of work being done here at the university. Just wanted to get your take as someone who's in the thick of the research.
I think it's a hotbed because it has to be, given that we have a school of pharmacy, a school of optometry and vision science, and applied health sciences. There is a natural tendency for those disciplines to want to publish health research. I think there's also an institutional habit of looking at things differently and producing innovative ideas in terms of healthcare problems, health problems.
Fantastic. And how far along is the research? How much longer do we need to go to see some advances in some of the areas that you're researching?
I think we're within a couple of years. I think the morphology assessment I'm getting more and more excited about as time goes on, because I can see that we're beginning to make progress with it, and the posture test in diabetes, I think again can make a huge difference within years. We're not talking tens of years, we're talking 2 or 3 years potentially.
Fantastic. Just looking through, seeing any questions in the chat. Are there other areas that the research that you're doing, are there other diseases, degenerative diseases that you see some of your research being applied to?
Yes, I mean, one would be multiple sclerosis. So that is another form of neurodegenerative disease, but it's one that is not age related and it typically doesn't result in dementia. So that is another area to look at. Also, there are certain series of vascular diseases where this research can be applied, particularly age-related macular degeneration.
Okay. And as the population starts to get older, what kind of effect will that have on just the recognition of your research and the importance of your research?
Well, hopefully it will have a positive effect. I mean, one thing I didn't really mention in the presentation was the huge increase in age of the population. The population is aging, and the larger numbers, primarily because medicine has resulted in such huge leaps forward. The fewer people, people live longer now, and that has resulted in the rise of other diseases, these chronic diseases such as diabetes, Parkinson's, Alzheimer's. Neurodegenerative diseases have been described as a pandemic that is just starting. And these descriptions are from very respected researchers. They're not just off the cuff comments. They're literally saying that the problems associated with neurodegenerative disease are so apparent and so of such a magnitude that they could overwhelm healthcare systems within the next 10 or 20 years if we're not careful. So we need to have better tools to manage them and to delay the onset of these changes.
And do you feel that, or in your research, do you find that Is it just, is there a rise in these degenerative diseases because the population is just getting older, or are there environmental factors that are playing into that as well?
There are environmental factors. Certainly in Parkinson's disease, there's a strong suspicion that heavy metals in the environment, pesticides, insecticides, herbicides, industrial degreasing agents, all contribute to the increase in Parkinson's numbers. I have no family history of Parkinson's at all that I know of, and it's been suggested that exposure to some of these agents, especially at a young age, can result in Parkinson's later on in life.
Okay. So it's, it's not something that just kind of clicks. It's something that could be with you for a while.
Yes, yes, absolutely, absolutely. The
Are
worrying
there,
thing is that everybody's exposed to it. So, people like myself could be just the thin end of a huge wedge, which is really troublesome.
so are there things that people can do to address some of those environmental factors?
It's a good question. I guess avoidance of pesticides, herbicides uh, in the environment immediately around you. I certainly don't use any such chemicals at this point in my life. But yeah, in some ways it's a problem that is hard to define. But certainly there are environmental hotspots for things like Parkinson's as well. And there needs to be work done on looking at things like water quality and the incidence of these diseases to see if there is evidence of such a relationship.
Right. Well, thank you very much. I think that's all the questions that we have. Thank you, Dr. Hudson, for your presentation and for shedding light on the research that you're doing here at the University of Waterloo, as well with the partnerships that you have, not just here in Ontario, but around the world as well. So thank you so much for taking time out of your day, and thank you to our attendees for tuning in, learning a little bit more about the research that we're doing here at the University of Waterloo. Again, an email is going to be sent to you shortly to get your feedback and to get any topics or themes that you'd be interested to hear about in future webinars. So thank you, Dr. Hudson.
Thank you, Carlos.
Thank you, everyone, and have a great day.
Bye now.